Okay, so now that we talked about the proper indications, the risks involved, which are very important, how to generally prepare the patient, now we're going to go through the actual procedure. So you want to position the patient. They're usually going to be on their back. You need to get their arms to the side and either restrain them if the patient is more awake and responsive and not going to be cooperative, or just simply move them out of the way if that's not an issue. It is a sterile procedure, so you're going to have to prep your spot, all right? Unfortunately, on a chicken, there's no nipples, but where you want to go is the 4th to 5th intercostal space in the mid-axillary line, okay? A good hint for that is, let's just say that's your nipple line. If you come to the side right about the nipple line, as long as your patient doesn't have any anatomic abnormalities, that's going to put you just at about the right place. Now, the reason you do not want to go lower is because, remember, your diaphragms are curved on, obviously on both sides, with the liver living under the right side and the spleen and stomach living under the left side, and that's what you're trying to avoid. So it appears as though you're going quite high, but you're avoiding the abdominal organs. Okay, so you're going to just, obviously you get your sterile gloves on, and you're going to prep this out sterilely. Depending on the patient's status and how urgent this is, you can either use local and or a combination of IV sedation or pain meds for your patient. Okay, so you prep it out. Now, where are you going to go? All right, directly. You want to look for, you're going to feel your ribs, okay, and you want to go on top of the rib. You want to go on top because your neurovascular bundle runs underneath the rib. The rib is, think about it like this, your rib is protecting your neurovascular bundle. So therefore you want to go on top of the rib to avoid that, okay? All right, I'm going to use my slip tip syringe. I'm going to attach it on my angiocath, okay? I'm going to practice, make sure I can withdraw with one hand, all right? Because once I enter the chest, from the minute you enter the skin, you're going to be aspirating, okay? And that's so when the minute you hit your fluid or hit your air, you're going to know about it, and you're not going to go past it, and you're not going to injure the lung. Your other hand is going to stabilize your needle. Okay, the best way to do that is to put these 3 fingers, actually rest them, okay, not push, rest them on the patient so that you have your thumb and index finger ready. And as you go in, when you find the right spot, your thumb and index finger can grab this, okay, and not move, all right, and you can change your syringe, attach whatever, and your needle is stabilized with your patient, okay? If the patient moves also, your needle and your hand are going to move with them, okay? All right, so nipple, 4th or 5th intercostal space, mid-axillary line. You're going to feel the rib. You're going to go on top of the rib. Thank you. Okay, and the minute you go through the skin, you're going to start aspirating. Okay. Go, go, go. There we go. Okay, bingo. All right, that's your flash. Now, of course, this is liquid because I can't show air, okay? But it works the same way. If you were going after a pneumothorax, you would feel that rush of air. You would pull your syringe and the suction would stop, and you would actually actively pull air out, okay? So again, the minute you get what you're going for, these 3 fingers and your hand on the patient, and you stabilize your needle, okay? All right, now this does not move for the rest of the time, okay? This way you can do this, you can change your syringe, all right, whatever you need to do, okay, and you have your nice void of whatever you're going after. All right, see how easy this is to get the slip tip off? Watch what happens if I'm going for a bigger syringe, and let's say I'm really trying to evacuate. Okay, here we go, blah, blah, blah. All right, and I'm not getting any more. Well, gee, that wasn't a very good thing. Okay, the lower lock's not supposed to do that. That was the whole point of that. You try to disconnect this, and just take my word, it didn't work this time, but it's very difficult to get the lower lock off. You can see this dripping, and that's what should happen when you're in that cavity. Okay, now, so you've got your nice fluid. Okay, now, someone obviously hands you do not reach over and grab something unsterile. You get your setup. This is your Heimlich valve. Okay, it's a one-way valve. You attach it to the connector. Okay, these come pre-done in the kits. This is not exactly it because we didn't have a connector, so I made this one, but it's the same idea. All right, you just simply attach it to the blue port, and if you look on here, it says flow direction, which means from the patient to this and out. All right. So, and it says connect chest tube to this end, all right? So you want to put the connection on this end, and this goes to the patient. Okay, so if we were going to leave this in, all right, then it's just like an IV. What you do is you stabilize your needle, you push your angiocath off over, and if you're all the way in, then you actually do have to withdraw your needle, okay? And you connect your Heimlich valve. Okay, and again, this isn't really the one that comes with the kit, so it's not going to work perfectly. And then you stabilize it. Okay, that should fit into this end, all right? And you secure the angio to the patient. And now you've got your one-way valve system, so the air can come out through here, and you leave this end open. If you attach something here and close it, you will now have a closed system, and your tension pneumothorax will, believe me, recollect, and your patient will go into physiologic distress again. Okay, so do not close this valve. You leave it open. Okay, and that way the air can come out, but it won't go back into the patient. Okay, and if you pull out, then all you're going to have is a small size, relatively small size hole, and you can, watch to make sure. Watch. All you're going to watch the small size size. Watch. You can watch. Watch to make sure. Watch. All you're going to is a small size relative. Okay, so now we're going to do it in real time. And remember, if it's a true emergency, this is all you need. You need your needle, your 3cc syringe, your betadine. You don't even have to have towels depending on how emergent it is, but we'll use towels, and your sterile gloves. Okay, so we're going to pretend that this is real. The patient's decompensating. All right, so I'm not going to have to worry about, drugging the patient. I'm, not going to worry about a little lidocaine. Okay, if you wanted to, you could have somebody given fentanyl while you're doing the procedure. All right, so let's start. Okay, I walk up to the bedside. Patient's desat and becoming bradycardic. Mitch, I'm going to need an 18-gauge needle, a 3cc slip top, my iodine, and some towels. So if you can first open the iodine while I put my gloves on. Okay, all right, now if you will get my needle and my 3cc syringe open, and open my drapes. So you can hand them to me. Give me my drapes first. Okay, drapes. Okay, needle. Open my needle. Okay, you drape that out just enough to be safe. Needle, syringe. Alright, I got my landmark. I find my rib. I go put it in. I start aspirating. Okay, on top of my rib. There we go. Bingo. Alright? That took all of 20 seconds. Okay? That's how fast you should be. If you need to practice over and over, you need to have it drilled into your head exactly the minimal things that you need. That's the needle, the syringe, your gloves, your betadine, and a drape, okay? So because you need to have somewhere to stabilize your hand. All right, so now the patient's sats are up, heart rate's coming up, you save the day.